So Greg normally has me do the spinal deformity talk. No, that's not true. That's a lie. Or how not to do the spinal deformity talk, I guess, or how to create the spinal deformity. There we go. That's it. So today I'm going to give the talk on posterior decompression techniques, primarily because most of the surgery we do to decompress the neural elements is done from a posterior approach. So that's primarily what we're going to focus on, and the majority of our decompressions are going to be done in the lumbar spine. So I'm going to talk on that, pretty much focus on that. So that's where we'll get started. I'll talk a little about cervical and talk a little bit about foraminotomies, but primary talk will be on posterior lumbar decompression techniques. All right, spine surgeon quotes. Let's start here. How many times have I been sitting in the meetings and we'll talk about, there's nothing complicated today on the schedule, just a bunch of lammies. And so we see this all the time. This is a really common problem. Patient with a spinal stenosis, we're going to go decompress it. And so other quotes that I hear, one of the quotes somebody told me in my training is, nothing bad ever happened to me that did not involve clear fluid. I'll let you guys decide as you go on through your career how that really works out. And then I did hear a quote once, weird, I was doing the decompression and there was like no dura. So I think what comes up for me in doing decompression surgery is that a lumbar laminotomy and microdisc through a 1.5 to 2 centimeter incision can be just as hard to do as an instrumented spinal fusion if we don't know how to do it well. So anything we struggle with, we're in the operating room sweating. This is the potential outcome on the right. And these cases can really turn into train wrecks if they're not done well. So today I'm going to give a little bit of talk about how I approach decompressions from a technique standpoint, from a patient approach, and then you guys can take that into your practices and then apply the principles as you see fit as you go forward into your practices. So what are we doing when we're decompressing the spine, or why are we even doing this? So, one of the things that we can do as spine surgeons is we can unpinch pinch nerves. Obviously, a ton of our pathologies involve some form of either degenerative or post-traumatic or some other causation for neural compression that we have to then go in and decompress. And the vast majority of those are done through a posterior approach, removing some part of the posterior elements of the spine to make room for the nerves. So what are the causes of neural impingement? Well, spinal stenosis is simply the encroachment into the spinal canal from the enlargement of the posterior spinal elements or from the disc pathology that occurs as a segmental breakdown of the spine. So this cartoon is basically showing the encroachment of the nerves from ligamentum fibulum hypertrophy, facet joint hypertrophy, and then overall disc protrusion from just the disc degeneration over time. Normal spinal canal here. And then on the MRI, we see a variety of different pathologies. We see the disc degeneration here. We see a synovial cyst that's formed, and then you can see the degree of neural compression from the narrowing here at L4-5. You can have instability that creates this in a spondylolisthesis. Deformity can create this, particularly neuroforaminally and a bad scoliosis. And then you have acute changes that can occur, fractures, which are often, with fracture surgery, you're often approaching that from the front of the spine, an anterior approach. We're not going to talk about anterior decompression. I think that's really a different talk because it's a different problem. But most disc herniations in the lumbar spine in particular are approached posteriorly. And then obviously for anatomic reasons, in the cervical spine and thoracic spine, we have to approach disc herniations through a different approach because of the nature of the neuroanatomy. Other causes for spinal compression of the neural elements are neoplasm and infection. And the vast majority of those are also approached through a variety of approaches. Infection typically in the lumbar spine is approached from the back. The destructive part of it can be approached from the front, but to decompress an epidural abscess, most of us are going to be approaching that posteriorly. So these principles apply. Hold on, guys. I just lost my. There we go. So we talked about the different pathologies. Sorry about that. Disc herniations, location, the type of herniation you can see. Is it contained? Is it extruded and sequestered? This is an MRI showing a sequestered fragment below the disc base at L4-5. You can have recurrent disc herniations, which require a different approach to get in. Stenosis, spinal stenosis is the generalized enlargement of the neural structure or of the surrounding structure around the neural elements. Facet enlargement, ligamentum flavum hypertrophy, synovial cyst, which this MRI shows a large fluid-filled cyst that comes off of the facet joint. This is a classic appearance of a synovial cyst. So again, the stenosis caused from a variety of causations. And one of the things we have to keep in mind when we do look at spinal stenosis is, and we'll talk about imaging here next, is the calcification of normal structures. And then for revision surgery, we have previous laminotomies or laminectomies that have been done. You've got to account for that if you've got a recurrent neural compression problem, that there is no normal anatomy or very little normal anatomy. So there is a technique involved in doing that. And then if you have had a prior durotomy and you've got to work around that to get back in around the neural structures, all of these require technique changes for your posterior approach. So when we image the spine, we ought to say, okay, well, how do we image the spine in order to make sure we know what we're doing before we get in there? So X-rays for alignment and determination of instability. If you're going to do a decompression, you want to know your deformity, whether there's a scoliosis and a neuroforaminal encroachment from the collapse to one side. And then an instability problem where you may actually have to consider doing something to fuse the spine, because a decompression may require you to remove so much of the posterior elements that you're going to create a worsening instability. I still think MRI is the gold standard to evaluate the neural elements as well as compression of the neural elements. And then sometimes I think a CT is very helpful to evaluate structures, especially where you've got somebody with a very chronic problem or with something that, in this case, if you look at that MRI there, you see what appears to be a very large disc herniation. And I don't know if you guys can see my cursor here, but you see what looks to be a very large disc herniation. This patient actually turned out to have a very large, partially calcified synovial cyst. That's what that is. And this is the CT after treatment. I did a fusion because the disc herniation occurred below a fusion. And this is the residual, when I went in there, this is the residual calcification that was in the synovial cyst. The other thing, what we'll see commonly is calcification of the ligamentum flavum. So this presents a unique problem, because here you can get in and you go to do what would be considered to be a standard decompression, whether a laminectomy or laminotomy, and all of a sudden you have no normal space or interval between the dura and the neural elements, because everything that used to be soft tissue is now calcified right down to the dura. So knowing that ahead of time, but with your imaging, can be very helpful. In the case of this particular patient, a CT scan that would have been done prior to this would have told me a lot more about the pathology, because when I get in there, I thought I was looking for a disc herniation, and I very much found a cyst. So just things to think about. When we do surgery, there's different principles we use. There's variable techniques for doing a laminectomy, laminotomies, and foraminotomies, and obviously depending on the area of compression. As I mentioned, spinal cord requires us to approach the decompression typically either through a full laminectomy in the cervical spine for cervical stenosis, and also in the thoracic spine. Approaching disc herniations typically have to be done anteriorly unless they are very far lateral, because of the cord anatomy and the fact that it can't be retracted. So these require different approaches for decompression. And then some problems just simply require indirect decompression to effectively treat the problem, primarily neuroforaminal stenosis, and in some cases deformity. So these are just examples of that. So the MRI on the right shows a problem we would approach posteriorly, typically to decompress spinal stenosis. Here is a spinal cord compression. We're also approaching posteriorly, but here you might be able to do laminotomies. In the cervical spine, you would do a laminectomy. Or approach this from an anterior approach. You can do that as well. So when we talk about lumbar decompression techniques, the principles, I think the pathology dictates the technique. I typically do laminectomies when I need central decompression and I need access to the neural structures. So if we're going to decompress the spinal canal to make room to do something intradural, or if there's significant cauda equina compression at the thoracolumbar junction, I think a full laminectomy is necessary in order to get access to the neural elements. And the cartoon basically shows the surgical technique where we're going to come in, remove the spinous process, the posterior lamina, and then undercut to make sure we're removing enough of the facet joints to decompress the lateral recesses, still trying to preserve enough of the posterior facet to maintain stability. This is the classic laminectomy approach. And you can use various tools. We'll talk about the tools here in a minute. But this is the classic laminectomy operation. It's also necessary when somebody has a congenitally narrow canal. It's really difficult to do. Patients with congenital stenosis in the lumbar spine through laminotomy technique. And of course, at the upper lumbar and the thoracolumbar junction, typically a laminectomy is used. And then in the thoracic spine and cervical spine, this is your technique. So. But we, in the lumbar spine, obviously will be doing decompressions of the neural elements now, trying to do less invasive approaches. So the cartoons really kind of show, I think, what are the corridors to do access, to provide access to the spine for removing most disc herniations, most synovial cysts, and then spinal stenosis now, at least in our practice, is typically done through bilateral laminotomy techniques, the goal being to preserve the posterior spinal elements as much as possible. So we have the ability for the muscles to reattach to the posterior spinal elements to preserve functional stability and capacity. So that's the idea. So here we're using these tubular type approaches, so small incisions, which they have to still preserve the facet, and you can actually, in some cases, do a bilateral decompression from a single side. So this is just the idea of doing a trajectory to be able to do the same type of decompression through a unilateral approach or bilateral laminotomy technique, which is the cartoon with the yellow tubular type visual corridor. And I think the key thing here is this doesn't necessarily represent a tube. It also represents your visual corridor, what you have to see to be able to do the surgery. So let's start with getting the patient in the operating room. Obviously, for posterior decompression, you're going to place the patient in the prone position. The Wilson frame on the left versus the post Hall frame on the right. With a Wilson frame or some form of lumbar flexion position, you're going to open up the interlaminar space. So this generally tends to make posterior decompressions potentially a little easier to do. You potentially have to remove less bone to be able to see, whereas in the Hall frame where the spine is extended, which is optimal for spinal fusions, where you want the patient in their appropriate lordosis, it lessens the interlaminar space. It crowds that, so you have to potentially remove more bone to see the neural elements. So just keep that in mind when you're positioning a patient for decompression. What's the optimal position? The other thing that you want to do is make sure that the abdomen is decompressed. So one of the things that comes up with both the Wilson frame and the Hall frame is that they both decompress the abdomen. So ideally, you want a table that has the abdomen decompressed because you can get a ton of back bleeding. The epidural veins tend to fill with abdominal pressure. And I've actually been in cases where we could not see at all because the epidural bleeding was so significant that you could not safely do the operation. So we've had to abort procedures before we understood that our positioning was creating a potential problem here. You want to know where your lights are so you can be able to visualize. And then I've gone to using the microscope. I used to do all of my decompressions either through loops or through my eyes, but I really find that the microscope has made the operation easier, more reliable, safer, and more thorough. So I think an operative microscope and positioning that and using that is a super helpful tool for really getting optimal outcome for the patients. And then we're not going to talk about endoscopic techniques, but this is for standard open techniques. I think the microscope is critical. So the next thing we have to do is once we start, if we're doing a single level decompression, one of the things you have to do is you have to localize where you're operating. If you choose to, if we've all seen patients that have had single level laminectomies 20, 30 years ago, and they have these really long incisions. Well, one of the ways you can localize is you can simply open the entire posterior spine and then count from the bottom to get to the level you need. I think that's a little invasive, and with the ability to use fluoroscopy and intraoperative x-ray to be able to see, I think targeting your level and creating small incisions is the standard of care now. You need to make your incision at the level. You need to have the incision big enough to be able to see what you're doing, whether you're using a tube or an open approach. You have to open up enough to see as many levels as you are doing. So again, the incision is based on how much you have to see a heavier patient requires sometimes a longer incision. Smaller patients can be done through smaller incisions. I've talked a little bit about getting the retractor in the right position, whether you're using a tube or I use a modified tailor, which is very thin. This is a 17 to 18 millimeter wide tailor that I will use in a 2 centimeter incision. I think it allows me the same visual corridor as a tube and still has access to allow me to go superior, medial, and inferior and lateral with enough visualization. I've got some video now finally in this talk so we can actually look some of the video of what we're seeing here. But again, the key thing here is do as many fluoro spots or x-rays as you need to do to be able to confirm that you're at the level you want to treat. So typically, I put a spinal needle in first and then my retractor afterwards, and I will do 2 typical fluoro shots to make sure that my retractor is at or below the level of the facet of the disc space that I want to treat. If the tip of the retractor is above the disc space, you are probably at the interlaminar space at the level above. So it's key to make sure that you're not fooled by your lateral x-ray, and also make sure that your fluoroscopic angle is correct. In a deformity, especially a scoliosis where you're doing a decompression, you can sometimes be fooled because of the obliquity of the patient. You may be at a level above or a level below, not at the correct level, because you're not getting a true lateral of the x-ray of the level you're trying to do. So just get as many fluoro shots as you need to make sure you're at the right level, because it's really disheartening for a patient to wake up, have their symptoms still be present. You've done this operation that you're all proud of, and you've done it at the wrong level. So just things to think about. This is key. I mean, just before you do anything, make sure you're at the right level. So once you're there and you're now going to visualize, you've got to remove enough soft tissue to be able to see. This cartoon shows the standard kind of, I actually use this even through a very small incision. You can do it through a tube, you can do it through an open approach. And I would argue that if you have good technique with the right retractor, the actual exposure is about the same. You need to be able to see the lamina that you're working on. You have to control bleeding, you have to have a lighting and visual corridor, and then you have to make sure that your retractor is stable in its position so you don't lose your corridor. And so these are all things you have to do. So you're basically creating the working field. So here's a video, and I'm going to run through this. Hopefully it'll go through. I just put these in, so let's see if it works. All right, so this is a diggity. So this is the interlaminar space at the level I'm working at. I'm getting exposure. I'm going to run through this pretty quickly so it doesn't take forever. But essentially using the Bovie, getting the bony elements exposed. The facet is to our inferior part. The lamina is superior to the left. The inferior lamina is to the right. I'm removing the soft tissue off the spinous process to be able to see the bony elements here. Lexel takes that out, and then try to make sure I get hemostasis with the Bovie. So now we're basically lamina here, facet joint here. This is the interlaminar space we're working at. So once we have visualization, now we have to get into the spinal canal to see what we're decompressing. So we have to remove bone first, typically. You have to remove enough bone to visualize your pathology, access your pathology, decompress adequately. You want to remove enough bone so you're not getting a complication trying to get things decompressed by trying to work into too small a window, and you also have to control bleeding. So you have to remove enough bone to be able to do the job you came in to do, whether it's through a full laminectomy or a laminotomy. You have to be able to do the job you came in to do. So you have to remove enough bone to be able to do that. So what are our techniques for doing that? I've gone primarily to a diamond burr. Thank you, Bob Eastlack, for introducing me to this. I used to use a cutting burr for everything, but the diamond burr for me has become the workhorse tool for bone removal. It cauterizes as it removes bone, which significantly reduces the bleeding that I have during the operative intervention, and provides a safer way to remove bone for me in my hands. Other surgeons may prefer a cutting burr. I don't think it matters. You just have to have a tool that works for you. Some people do it with all Kerrisons and other mechanical tools. But for me, the diamond burr in combination with Kerrisons and curettes has become the way to remove the bone that I need to get out of the way to do the work. What are the issues with the diamond burr? Well, they get really, really hot. That's a way they create coagulation, but it also, and cautery, but it also can cause a thermal durotomy. So you can get these things so hot that if you're next to the dura with the tip of this, it'll burn a hole right in it. If you set it on the drape, it can burn a hole right through the drape. So you have to keep an eye on that. And then you have smoke throughout the procedure that you have to suction continuously to be able to see. You also have to apply more pressure to the tip of this burr to get it to remove the bone. So you could have loss of control of the tip. And then there's a ton of very fine bone debris that occurs where you're having to constantly clean the suctions or change the suctions. So here we are. This is a video of using the burr, and I'm going to go through this quickly. This is the diamond burr. So I'm going to use the burr to create my field here. So I'm actually going to medialize the spinous process a little bit here. It actually removes some of the soft tissue there. I'm trying to create the interval so I can see the top of the spinous process, in this case of L5. This is L4-5. And then I'm going to remove just a little bit of the medial facet, and I'm going to create my window for my laminotomy. So I'm going to enlarge the opening of the interlaminar space now with the burr. You can see that happening. You can see the bone debris. You can see some of the soft tissue being pushed away. So basically, this is the process, and I'll go through this pretty quickly here. So we'll speed it up here. I wish it was that fast in real life. And now I'm removing bone, enlarging the laminotomy. You can see getting hemostasis throughout. So you can see the final product here of the initial laminotomy. That's a 7 millimeter burr. I've gone to that for the gross debridement for creating my interlaminar window. And then, so here we talked about bone removal. They have the cutting burrs. You can use less pressure. They usually are directional, either an end cutter or a side cutter. So you have an end cutter here, side cutter. This is the diamond burr. This is a round cutting burr. Again, you get more bleeding with these, and if you hold a cutting burr near the dura, you can get a different form of a durotomy from the cutting burr. Kerrison punches are also workhorses in removing bone. They're hand controlled, or they actually have powered ones as well. I've never used one of those. You have a foot on there to kind of protect the neural structures as you're cutting here. You need a safe plane to work. So one of the things you'll see in the video is creating a safe plane to use the Kerrison punch. If the bone is extremely hard, you can get hand fatigue. You can actually create a failure of the Kerrison punch because it has a hard time cutting through the bone. So yeah, it becomes less efficient, and you potentially can create durotomy from simply trying to get hard bone away from the neural structures. So again, a combination of the tools typically is helpful. Going back and forth between the burr and the Kerrison is what I typically will do. Once you've got the appropriate amount of bone resected, you've got to complete that bony work first, and then making sure that you I leave the ligament inflavum intact. And here you see in the cartoon, removing the ligament inflavum. In this case, the bone's been removed. Now you're looking at ligament inflavum, and then underneath, obviously, the ligament inflavum is the dura. There's lateral recess you've got to worry about. So there's stenosis oftentimes in the lateral recess. So we're going to make sure we remove enough bone and to get access to the lateral recess to decompress the neural elements as well. So in my situation, I always try and visualize the superior articular process and the inferior articular process as I remove it, but with care taken to avoid over resecting the facet. So I'll use a curette to separate bone edges from the ligament and capsule of the joint. And I'll use a Woodson elevator and a scalpel to cut the ligament inflavum once I've got all of my bony work done, and I'm going to take my ligament out last. So we'll look at this now. So here's a video of that. So here's the burr. Once again, the diamond burr. Still now we're working the lateral recess. We're taking the laminotomy superiorly, cephalad a little bit more, removing bone. I work right on the junction of the bone to the ligament. The ligament is my protective structure at this point. You have to modify this for a revision. Now you can't just put the burr up against the scar from the dura, but you can use it in a different way. And I'll use a smaller burr if that's the case. And then I'll carefully redefine the margin between the bone and the scar from in a previous laminotomy defect. But here you can see, I'll stop this. You can see this is the inferior articular process. You're starting to see the superior articular process come in. This is the actual residual facet joint here medially, and we're going to make that go away. So go to the next video. So again, we'll talk about once we get ligament and facet capsule removal of the dural exposure. Again, you have to remove enough of the lamina facet to see the tip and the top of the superior articular process. I try and see that out laterally within the laminotomy. We talked a little bit about the calcified ligament, because if the ligament is calcified, you may get a false edge to the true lateral recess. So if the ligamentum flavum is calcified, it's sometimes very difficult to find the true bony edge. And you also don't have a normal interval between the ligamentum and the dura underneath. So you got to be wary of that. And like I said, having a CT sometimes is super helpful so you know what you're getting into. I try and decompress out to the level of the medial pedicle wall of the inferior vertebra. I think that gives you the best chance to get the traversing nerve root decompressed as a part of a decompression for either stenosis. It also gives you the ability to get lateral to the dural sac and the nerve root as it traverses to make sure you can get access to the disc herniations that are there. Again, to getting to the medial pedicle wall of the inferior vertebra is kind of my landmark. So I feel that with the tip of the curette and the Kerrison. I will push the epidural soft tissue off the undersurface of the ligament when I'm removing it. So I try and leave the fatty tissue and the other connective tissue towards the dura. I think you get less chance of durotomy. And then when in doubt, confirm your safe plane with a curette or a Penfield before you try and cut or remove anything with the Kerrison or the bursa. In this case, you've got the significant calcification of the ligament, which tells you that you're probably going to have to go way more medial to remove this calcified ligament. So the cartoons kind of show the zones where you're working either laminectomy or laminotomy, and then how you basically have to get access to achieve adequate neural decompression underneath. So here's the separation process of the ligament. And here I've removed, if you see the blood at the very top corner, that's where the ligament detaches from the undersurface of the superior lamina. So I take my laminotomy up high enough to make sure I have that interval so that the ligament at the very top corner under the spinous process has been detached from the undersurface of the lamina. And now you're seeing me find the medial border of the superior articular process of the inferior vertebra. I'm using the curette to find that interval. There is some calcification of this particular ligamentum flavum, so I'm using that to find that interval. And I'm actually now going to take a straight curette and try and find my true edge of my inferior lamina. And now I've just detached it. You get a little more bleeding, so you know you're now in the epidural space again. So I know I've detached that. And now I'm going to use the curette once again to come around and find the superior edge, because that's where my Kerrison is going to be able to work. But you can see how much more medial you actually have to go. The detachment of the ligament has to occur more medial. So the superior articular process is considerably more medial because this patient had significant lateral recess stenosis. So I'm going to decompress that as a part of the procedure. So that's the curette work there. And then we'll go through this. The second video is now I'm going to use the Kerrison. I've made that interval. I've used the curette to create my interval. Now I can use my Kerrison to safely work in the same interval. So I'm removing the inferior edge. I'll go through this quickly. You have to watch me do a bunch of Kerrison work. Sorry, guys. But you'll see me work methodically around, again, getting the Kerrison tip in around that bony edge immediately. So you can see how I'm able to come around because I created the edge. There, I pulled a little bit of the lateral ligament out. I usually like to have a little cleaner edge. So you'll see me nibbling. I just take tiny bites so that I can basically work that out. I think trying to get a big bite, you can trap more soft tissue. So here I'm just trying to create the bony edge. Oh, hold on, let me go back. So we'll finish that all the way around. Now I'm taking the superior edge here. So now I've got the ligamentum flavum sitting detached almost all the way around. I'm taking a little more bone at the top of the inferior lamina. And then this is a picture of the completed laminotomy. This is the dura. This is a disc herniation. You can see disc material. This is a right-sided approach. This is cephalad. This is caudad here. Dural structure here. The nerve root is here. This is disc sitting under there. This is a picture from a previous case. You can use the suction. You got to retract the dura out of the way. So you got to adjust your scope to see. So you're constantly adjusting your microscope to be able to visualize the neural elements. Bring it more medial if you have to. Bring it more lateral if you have to see more medial. I will use a cottonoid to do blunt dissection in the epidural space, the Penfield and a small curette. Control your bleeding with the bipolar and hemostatic agents. Gently retract the neural elements in the dura, and don't bite or pull if you can't see. One of the things I will continuously do is try and create a visual plane, create an edge between the dura and the residual ligament so that I can see, and that's, I'll show that on the next video. So here we go. So you can see the dura, the residual ligament. I've created enough laminotomy here to basically, you'll see me bite just the edge to create a little more room to work. Again, the hard bone there, you can see the working the kerrison, but I'm basically working in the edge. The suction is keeping my integral so I can see. I'll go a little faster here. All right, so now so here you guys have to, I'll put this in so you can see how I do this. So I've got that interval, I widen that interval with the curette to get to the superior edge of the ligamentum flavum. Now I'll flip a Woodson underneath in the interval between the ligamentum and the underlying dura. And now I'm going to use a 15 blade and I'm going to cut down on the Woodson so I can see that cut. Sometimes I'll reposition the Woodson to make sure I'm right underneath ligamentum. And I'll pull it so I can see what I'm cutting. I will go above the fat layer there. I just move that into a different plane. And then I'm going to grab it with the pituitary. They're going to pull it off. So I will push the fatty tissue towards the dura. I'll come right off the bottom of the ligament. So you see me work with the Penfield 4, working the plane. I come off the ligament. I'm going to create the separation plane. Tension on the ligament of flavum really allows it to come out. So you can see working in the lateral recess there. I'm going to go back and forth. So I've got it free now. I've almost detached it completely lateral, and then I'll use my curette to finish it. Oh, I left some. So basically then I'll use the kerrison to finish that. And I keep the flat part of the kerrison up against the dura. So I try and bite away from the dura. All my bites with the kerrison are away from the dura. You'll see me get some more stuff out of the lateral recess there. Then basically passing the Woodson out the foramen. Use a cottonoid to get hemostasis and create a little more separation. You'll see there's a little more ligament off of the facet capsule and the joint superiorly. So I create a little separation plane. I'm going to use the cottonoid to create it, essentially use it like the ligamentum flavum, and I'll take that residual ligamentum flavum and use the cottonoid to protect the dura as I'm biting. So that's the last bit of the lateral recess, redundant soft tissue in the lateral recess there. And I think there's just a little bit more here. I got that out with sometimes I'll use the curette to pull that out. So that's that. Then finally, this is just this basically putting some flow seal in the epidural space to get the bleeding, cottonoid, finishing up the lateral recess decompression here. A little bit of smoothing my edges. So I'll use the curette to smooth the edges of the laminotomy to make sure there's no sharp edges. And that completes it. And then the flow seal to get the hemostasis. So what does it look like when we're done? So pre-op MRI for a patient with a 2-level laminotomy procedure. This is the post-op MRI showing good decompression of the lateral recesses, central canal. So this is typical. We preserve a ton of the facet. I probably could have done a little bit better job of taking the left-sided facet joint here out at this lateral recess, but this patient had done well clinically after bilateral laminotomies. Now we'll talk a little bit about doing a far lateral. So here the pathology is out lateral to the spinal canal. So you need a different corridor here. You have to start lateral to the facet and work typically disc pathology or foraminal stenosis out laterally. I try and, if I'm going to do access here for a lateral foraminal compression or intraforaminal disc herniation, as we see in the cartoon, here the trajectory to get in is going to be typically lateral, and you're going to have to come out lateral to the facet joint to see the pathology. My typical approach is to work from transverse process to transverse process and then define the lateral aspect of the facet joint and the lateral aspect of the pars, because that's where your pathology typically is. The disc space is going to sit right above the inferior pedicle. So if you're working at L4-5, it'll be sitting right at the L5 pedicle, so a disc herniation. And you can see in the cartoon here, the basic need is to medialize enough of the pars and the facet in order to be able to see and visualize the exiting nerve root under the microscope. And you have to remove the intertransverse ligament. There's a ligament that attaches from transverse process to transverse process. Typically, I will detach that from the top of the inferior transverse process, lift it up, and then you also have to remove it enough from the pars as you medialize the pars and the facet. You have to remove it here so that you can lift the intertransverse ligament up to then see deep to it to find the exiting nerve root, and then lift that up to find typically the disc pathology or the pathology you're after. If you're doing a foraminal decompression, you have to take more of the medial facet joint typically if you're not working on a disc, if you're just trying to do a far lateral foraminotomy for foraminal stenosis. But most of the pathology we're going to be doing here is involving disc pathology that extends out into the neural foramen. The exiting nerve root typically is above the disc herniation, but sometimes it's not. So that's where the microscope really is helpful in having good visualization and good hemostasis. I found that by preserving and not trying to lift off all of the intertransverse ligament, I get less bleeding. As you try and retract and remove more of the intertransverse ligament, you generally tend to get a lot more epidural bleeding and a lot of bleeding around the dorsal root ganglion. And you also have to do a lot more mobilization and cautery around the dorsal root ganglion. That tends to irritate it more, and you get more post-operative dysesthesias and paresthesias. So this is a typical setup for me for a far lateral herniation. You can see here on the patient's left, this patient has a huge intraforaminal disc herniation. You can see it here extending up into the neural foramen. So this is my typical fluoroscopy approach. Here it's kind of tubular based. I actually use the stainless steel opening retractor from Invasive. Here I find this is very helpful to be able to do both a tubular approach, but also to expand my operative window to be able to see as much as I need to make sure I can visualize enough of the anatomy as you need to. And I highly recommend it when you start, you make sure you understand where you are. You can always get bigger when you start, and then as you get better and better at this, you can use a smaller and smaller opening and work through a regular tube. But I've really found this to be helpful to be able to visualize the anatomy. So this is a typical retractor setup, AP fluoroscopy showing us over the facet. I've basically localized facet. So here the dilators go in over the facet joint, and then you can see with the final fluoroscopy on the far right lower corner, I'm at the disc space doing the work where I want to be based on where the retractor is positioned. Finally, talking a little bit about for lumbar decompression, doing a unilateral approach to do a bilateral decompression. Here it requires some fairly skillful work of the burr, and then you're leaving your ligamentum flavum. I think this requires appropriate patient positioning. Sometimes you have to rotate the table to be able to see across. You're going to remove kind of the inferior aspect of the lamina and come under and undercut the spinous process so you can see across to the opposite side lateral recess. So you can see the arrows show the trajectory of where you need to be able to see and where your tools need to work. You're going to take a burr across above the ligamentum flavum on the opposite side to remove the bone all the way down to the far lateral facet in the corner. I think this is a difficult operation to do, but it can be very, very effective if you're good at it. And you can see the CT scan showing the bony removal to get really good decompression of spinal stenosis from a unilateral approach, which means you're preserving a great deal of the contralateral facet joint. So especially at the higher lumbar levels, I think this is a great way to do a decompression of the spinal canal and still preserve the stability. I just did this on a patient at L1-2 above a previous fusion. And I think it's really helpful because I was able to preserve the facet joint on the other side without really taking much at all, just the medial side of it from the inside out approach. We'll touch a little bit on cervical foraminotomies. Again, posterior decompression, where we're used to doing cervical laminectomies for spinal stenosis and myelopathy. Typically, that involves reconstruction and fusion. But for the appropriate intraforaminal pathology in the cervical spine, you can do a good decompression and get really good results for disc herniations and some foraminal pathologies. Again, I think this is probably about 10, maybe 15% of cervical problems are amenable to this type of approach, but it's similar. You're going to localize, you're going to basically use dilators to get in, you're going to basically identify under fluoroscopy the appropriate side and level, and then you're going to basically open the retractor up to see. I still use the new invasive retractor for this as well, a 3-blade retractor to see, and then a keyhole foraminotomy is what they're showing here. You height the drill, you remove the inferior aspect of the lamina, take it out. Don't over resect the facet joint, but you need to be able to get up high enough to decompress the exiting nerve root, and then you're going to have to work out laterally enough to make sure that the bony foraminal stenosis is addressed. And in some cases with soft disc herniations, you can actually then retract the nerve root up and then remove disc fragments laterally. Obviously, you can't retract medially because of the cord, but you can lift the nerve root up and then remove intraforaminal disc herniations using a cervical foraminotomy technique. But the principles are the same. Localize, make sure you're at the right level, visualize, find the bony anatomy, and then remove enough bone and ligament to be able to see what you need to see. So in summary, you got to understand your anatomy. There's different anatomy variations of the facets. Deformity and instability create unique visualization issues with doing decompression, and you also sometimes have to remove more or less of structures because of deformity and instability. If you're concerned about significant spinal stenosis and you're worried about somebody having calcified ligament, get a CT scan pre-op. It's very helpful. Synovial cysts are their own unique animals. They sometimes are very adherent, so you have to go in knowing you may actually have to leave a part of the medial cyst wall on the dura. It's just impossible to get it off of there. And you also have to do typically a more extensive decompression. You have to get above the cyst and below the cyst and lateral to the cyst in order to make sure you adequately are decompressing the cyst. And the one image that I had, you saw that very large cyst that required a more extensive laminotomy. You have to get above and below and medial and lateral. So that required a more extensive laminotomy than typical for like you would use for a disc herniation. And then obviously for the disc herniation, what does it look like? How big is it? How much access do you need? And where is it? Is it cephalad to the disc base, meaning you have to remove more of the cephalad lamina? Is it caudal, which means you have to remove more of the caudal? Is it sometimes easier to get a disc herniation from the level below or above just based on where it's sitting? I harp on this, make sure you know where you are. Do as many x-rays or fluoro shots as you need. And if you are concerned about the fact that you've done the right level, put the Woodson elevator around the pedicle of the level you just decompressed, or bring your fluoro in to make sure you have just decompressed the level you wanted to decompress. Again, you do not want to have the patient come back to you at 1 month having the same symptoms and you get a post-op MRI and you realize you've done the wrong level. Remove enough bone to see, but be aware of where your facet is so you're not over resecting the facet joint. And it is a tightrope walk as you get higher up in the spine. I think the lower lumbar levels are much more forgiving in terms of your ability to get out lateral. As you get up to L2, 3, and especially at L1, 2, you can remove a ton of facet joint before you know it, and you're still not lateral enough to do the work you need to do. So you have to be thoughtful of that. And sometimes a laminectomy is the better way to go. And then finally, when you're doing these, take your time. I think one of the things that I've learned is that sometimes the pathology is humbling and you have to go slow enough so that you're not creating a different problem than when you started. So that's all I got.